Hello everybody, my name is Tarek Kafafy. I'm an Associate Professor of Cardiology at University. Today I am going to present to you a lecture about myocardial infarction with non-obstructive coronary arteries, the so-termed MINOCA. We will start our presentation with a case scenario, the answer to which we will discuss by the end of this presentation. We have a 53-year-old woman with hypertension, hyperlipidemia, who recently lost her job, presented with chest pain radiating to her left arm and jaw. Her symptoms lasted for 30 minutes and gradually declined. The initial troponin I was elevated. The EKG showed ST segment elevation in the precordial leads, and the echocardiography was notable for LV ejection fraction of 55% with subtle apical hypokinesia. So we are confronted with a case of acute myocardial infarction. She was taken to the cath lab. The coronary angio, as we see, shows no significant obstruction in the coronaries. However, there are some irregularities in the mid-segment of the LAD. So this is a clear case of myocardial infarction with non-obstructive coronary arteries. Which investigation to do next? This will be discussed in the context of this presentation. So in this presentation, we are going to discuss the definition of MINOCA, the diagnostic criteria, the concepts and pathophysiology, the epidemiology, the diagnostic modalities and algorithms, treatment and prognosis. First, the definition of MINOCA. It refers to the clinical presentation consistent with myocardial infarction without significant coronary artery disease. It incorporates a heterogeneous group of conditions that may involve both coronary and non-coronary pathological conditions, with the latter including either cardiac or extracardiac disorders. With contemporary position statements of the European Society of Cardiology and the update scientific statement by the American Heart Association, there has been a focus on MINOCA. However, despite these position statements, yet there's a great diversity in how patients with suspected MINOCA are evaluated and treated. According to the ESC Working Group position paper, the diagnostic criteria for MINOCA requires three important points. First of all, a universal AMI criteria according to the universal definition of myocardial infarction. Number two, a non-obstructive coronary arteries on angiography defined as no coronary artery stenosis more than or equal to 50% in any potential infarct-related artery. And number three, there is no clinically overt specific cause for this acute presentation. That is, there is no alternative clear diagnosis. It is noteworthy mentioning that MINOCA should be considered as a working diagnosis analogous to heart failure. So in itself, it's not a final diagnosis, but a working diagnosis that has to be implemented. According to the fourth universal definition of myocardial infarction, type 1 MI refers to the presence of a detection of a rise and or fall of cardiac troponin along with corroborative evidence of myocardial ischemia in the form of symptoms of acute ischemia, new ischemic changes in the ECG, development of pathological Q waves, as well as imaging evidence of new loss of viable myocardium or new regional wall motion abnormalities, or the identification of a coronary thrombus in angiography or by intravascular imaging. The hallmark for this type 1 MI is an atherosclerotic plaque disruption, either rupture or erosion. In type 2 MI, it has a different concept. It's the concept of a kind of oxygen supply-demand mismatch. So the reduced myocardial supply or perfusion could be due to a variety of conditions like coronary artery spasm, microvascular dysfunction, coronary embolism, coronary artery dissection, severe anemia, and other causes. While increased myocardial oxygen demand is due to sustained tachyarrhythmias, severe hypertension with or without left ventricular hypertrophy. With the fourth universal definition of myocardial infarction, a lot of challenges have been met with the definition of MINOCA. So the myocardial injury refers to conditions where there is a rise or fall of troponin that may be related to a broad group of conditions, and it's usually referred to as troponin-positive non-obstructive coronary arteries. And this broad concept entails separate entities either extracardiac causes like pulmonary embolism, sepsis, stroke, or ARDS. Cardiac conditions with non-ischemic etiology like myocarditis, Takotsubo cardiomyopathy, as well as the true MINOCA, which refers to conditions of myocardial infarction with non-obstructive coronary arteries like plaque disruption, spontaneous coronary artery dissection, coronary spasm, microvascular dysfunction, as well as thromboembolism. The definition of MINOCA is clinically pragmatic, and actually a lot of terms have aroused in literature, namely the troponin-positive non-obstructive coronary arteries, myocardial obstruction with non-obstructive coronary arteries, as well as ischemia with non-obstructive coronary arteries. So these different nomenclatures do not represent same concepts, although they are sharing some entities. So pathophysiologically, when we talk about MINOCA, we have the troponin-positive non-obstructive coronary artery as the broad term that refers to either cardiac or non-cardiac conditions. The cardiac conditions are either acutely presented in case of MINOCA or subacutely presented in terms of ischemia with non-obstructive coronary arteries. Both have either epicardial or microvascular underlying etiologies. For the MINOCA, the epicardial etiologies represent plaque disruption, spontaneous coronary artery dissection, thromboembolism, as well as vasospasm. While for the microvascular etiologies, it entails microvascular intraluminal obstruction or extravascular compression. All this will be detailed further in our presentation. For the MINOCA, epicardial causes represents the vasospastic angina, coronary artery ectasia with slow flow, while microvascular causes includes mental stress-induced ischemia, as well as microvascular dysfunction. What about the epidemiology of MINOCA? Well, MINOCA has been found to be present in 5 to 6% of acute myocardial infarction cases with a range between 5 to 15%. It tends to occur in younger individuals compared to obstructive type of myocardial infarction. Women make up to 50% of the MINOCA population, while they are only 25% of the population of obstructive coronary artery disease. So women presenting with acute MI are more than twice as likely as men to have MINOCA, whereas men presenting with acute MI are more likely than women to have obstructive coronary artery disease. Regarding the risk factors like diabetes, dyslipidemia, and hypertension, they tend to be less frequent in MINOCA. And the presentation is more often an NSTEMI rather than STEMI. So in this cumulative data from 27 large clinical trials and registries involving more than 176,000 consecutive MI patients, it was found that the percentage of the overall prevalence of MINOCA is of an average 6%, and only 1/3 of the patients are presenting as STEMI. This figure shows the traffic light sequence for MINOCA that was presented in the AHA scientific statement that classified the management of MINOCA into 3 different stops: the red, the yellow, and the green zone. So for the red one, this represents the stage of myocardial injury, patients having an elevated troponin with non-obstructive coronary artery. So in this case, we have to search for alternative diagnoses of extracardiac causes or some cardiac causes of non-ischemic etiology. From this, we move to the next zone, the yellow zone, where the working diagnosis of MINOCA is being established. And in this stage, we review the angiography for missed lesions. We assess the LV function via LV angiography in case echocardiography was not properly performed. And CMR here stands as a very important tool in order to diagnose conditions like myocarditis and differentiate it from Takotsubo or other forms of cardiomyopathy. And finally, we reach the gray zone where the established MINOCA diagnosis is being held. In this case, the role of intravascular imaging as well as coronary functional assessment and vasoreactive testing is being performed to reach a specific diagnosis. It's noteworthy that the working diagnosis for MINOCA has special entities. First of all, searching for a clinically overt alternative diagnosis is very important as a start, because it saves a lot of time and a lot of investigations that costs, and accordingly, it helps us to limit the resources. At the same time, we access the second important entity is the access to the cardiac investigations, because some of the investigations that are used for the diagnosis and the working diagnosis are actually costly, and they are not available in many of the health facilities like MRI, intravascular imaging, as well as FFR. It is very important to notice also that the working diagnosis of MINOCA is quite dynamic. So an initial diagnosis of Takotsubo could be changed after doing a CMR to a diagnosis of myocarditis and vice versa. So conflicting diagnoses still exist in terms of MINOCA diagnosis. So spontaneous coronary artery dissection could be conflicted with plaque disruption, and Takotsubo, as we have previously mentioned, with myocarditis. So it is very important to adopt an algorithm in the workout for MINOCA. So whenever we diagnose a patient having MINOCA, first of all, we have to do an LV angiogram while the patient is still in the cath lab. This helps to differentiate the wall motion pattern. Is it epicardial or microvascular? So if it's epicardial, then we search for epicardial causes of MINOCA, like coronary plaque disruption or coronary dissection, that could be identified using intravascular imaging like IVUS and OCT. In cases of coronary artery spasm and microvascular dysfunction, this could be also identified by using coronary function testing and vasoreactivity. Takotsubo, cardiomyopathy, and myocarditis could be differentiated using CMR and endomyocardial biopsy occasionally. And finally, coronary thromboembolism could be identified by TEE, by contrast echocardiography, and by lab investigations for thrombophilia. Now we are going to highlight some of the endotypes of MINOCA, starting with plaque disruption, the most common endotype. Well, actually, plaque disruption, in order to be identified in the setting of MINOCA, intravascular imaging tools have to be present, and OCT is preferable to IVUS because of the higher image resolution. What about spontaneous coronary artery dissection? It is defined as a non-traumatic, non-iatrogenic, and non-atherosclerotic separation of the coronary arterial wall by an intramural hemorrhage, creating a false lumen with or without an intimal tear. The separation can occur between any of the arterial layers, either the intima, the media, or the adventitia. The resulting intramural hematoma compresses the arterial lumen and thus compromises the arterial blood flow and can cause myocardial ischemia or infarction. Two pathophysiological mechanisms exist, either intimal tear or a spontaneous bleed in a vasa vasorum without an intimal tear. It is very important to notice that coronary dissection is a cause of MINOCA, but most dissections are not represented by MINOCA. MINOCA in spontaneous coronary artery disease have to have two important things. A predisposing arteriopathy, most commonly fibromuscular dysplasia, as well as a cardiocirculatory stress, which is most commonly the peripartal phase with the hormonal imbalance encountered. This both result in weakened arterial wall architecture and results in spontaneous coronary artery dissection. What about vasospastic angina and coronary vasospasm? It is defined as more than 90% vasoconstriction of an epicardial coronary artery, resulting in compromised coronary blood flow. It is noteworthy that provocative test is very important to identify positive from negative results because it has prognostic implication. It was found that patients with positive tests have higher incidence of death from any cause, cardiac death, as well as readmissions for acute coronary syndrome. What about coronary thromboembolism as an entity of MINOCA? Well, as we all know, the Virchow's triad for thromboembolism entails three important items, either endothelial injury, hypercoagulability, and blood stasis or slow flow. If all those are available together with an anatomic predisposition, thromboembolism will opt and happen. But it is worth mentioning that emboli might arise not only from thrombotic origins, but from non-thrombotic sources like valvular vegetations, cardiac myxomas, as well as calcific aortic valves. In this study for coronary thromboembolism and in the context of thrombophilia disorders, it was found that thrombophilia screening in patients with MINOCA was found in almost 14% of the patients presenting with MINOCA. And to specify the etiological thrombophilic factors, factor V Leiden, it was present in 14% of the patients, as well as antiphospholipid syndrome in almost 15%. Hyperactivity of factor VIII in more than 150% was present in 27% of the patients, and hyperhomocystinemia in almost 16-17% of the patients. Coronary ectasia. Coronary ectasia is defined as a coronary artery dilatation of more than 1.5-fold the diameter of the adjacent normal coronary segments. It entails slow flow, in situ thrombosis, as well as thromboembolism. This Kaplan-Meier curve shows that patients having coronary artery ectasia have more cumulative events compared to patients without coronary artery ectasia. The coronary microcirculation, what we can see actually in the angiography performed in the cath lab is only 5% of the total coronary tree. So this leaves us with a 95% of the coronary tree that cannot be easily visualized in the standard angiography in the cath lab. Well, when we study the mechanisms behind microvascular dysfunction, it entails a lot of underlying mechanisms, from arteriolar remodeling to intraluminal obstruction, extravascular compression, vasomotor abnormalities, capillary rarefaction. However, in STEMI, intraluminal obstruction by debris and thrombosis, extravascular compression by elevated left ventricular and diastolic pressure, and myocardial edema in the setting of STEMI, as well as vasomotor abnormalities, stand as the underlying mechanisms of microvascular dysfunction. The microcirculation obstruction occurred due to plaque debris as well as platelet neutrophil aggregates that obstructs the microcirculation, precluding efficient tissue perfusion. Regarding microvascular spasm is due to an interchangeable mechanisms of impaired vasodilatation versus increased vasoconstriction. Both can happen together. The impaired vasodilatation is due to endothelial independent mediators as adenosine and catecholamines, or endothelium dependent mediators like acetylcholine, serotonin, histamine, and bradykinin. Regarding coronary function testing and its importance in the context of MINOCA management, the CORE-MICA trial was an intriguing randomized trial for coronary function testing. It offered randomized 151 patients who have angina with non-obstructive coronary artery disease to one of two arms, an arm with invasive coronary function guided care and an arm of just the standard angiography guided care, and they followed these patients for the angina severity as well as the quality of life. The interventional diagnostic procedure adopted in this study entailed a continuous state of hyperemia using intravenous adenosine and with guide wire mediated measurements of fractional flow reserve that measures the epicardial artery lesions, as well as coronary flow reserve that measures the vasodilatory capacity of the coronary microcirculation, and the index of microcirculatory resistance, the IMR, that measures microvascular vasospasm. This was followed by vasoreactivity testing for the epicardial arteries by acetylcholine bolus and for the microcirculation through an acetylcholine infusion. This yielded three results, or three categories of patients: those with microvascular angina, those with vasospastic angina affecting the epicardial arteries, and those with non-cardiac chest pain. It was found that patients who were offered the invasive strategy had a better angina score as well as quality of life over 6 months compared to the control patients. So to imagine this three panels, the blue, orange, and green, represent patients with non-obstructive coronary artery disease on angiography. So in the blue panel, the patient was offered pressure wire assessment. It showed normal invasive physiology, so the FFR was more than 0.8, the CFR was less than 2, and the IMR was more than 2, the CFR, and the IMR was less than 25, which are the cutoff values. So when vasoreactivity test was performed using acetylcholine, vasospasm was revealed in the LAD. So this patient was diagnosed as vasospastic angina. Accordingly, his therapy was tailored to calcium channel blockers and long-acting nitrates, along with smoking cessation and lifestyle change. In the middle panel, the orange one, the same patient, another patient with similar non-obstructive coronary artery disease showed abnormality in the pressure wire assessment. So the CFR was less than 2 and the IMR, the vascular resistance, was high. And this patient had no vasospasm on vasoreactivity. So this patient accordingly was diagnosed to have microvascular angina, and he was offered vasodilating beta blockers and also considered ACE inhibitors and statins. And it's noteworthy that nitrates may worsen the symptoms among those patients, so it was not prescribed. In the last panel, the patient in the green arm showed normal invasive physiology, normal output on vasoreactivity testing. So this patient was diagnosed to have non-cardiac chest pain, and he was advised to stop any anti-anginal treatment. The one-year results of the CORMICA trial showed consistent benefit over 1 year regarding angina severity as well as quality of life. I advise you all to read this latest publication, latest expert consensus document about MINOCA in collaboration with the Working Group on Coronary Pathophysiology and Microcirculation. It was lately published in Neurointervention. What about Takotsubo syndrome? It accounts for 1 to 2% of patients with suspected ACS. It is often triggered by stress occurring predominantly in postmenopausal women. It shows an end-systolic LV that resembles the octopus pot of the Japanese fishermen from where the name Takotsubo has been extracted. It is worth mentioning that Takotsubo syndrome should be considered separately since it is not considered anymore as a myocardial infarction according to the 4th universal definition of MI. According to the NSTEMI guidelines lately published in the ESC Digital Experience 2020, the following recommendations for MINOCA were advised. All patients with an initial working diagnosis of MINOCA, it is recommended to follow a diagnostic algorithm differentiating true MINOCA from alternative diagnoses. Number 2, it is recommended to perform CMR in all MINOCA patients without an obvious underlying cause. This is also a class 1 level of evidence B. It is recommended to manage patients with an initial diagnosis of MINOCA and a final established underlying cause according to the disease-specific guidelines. And finally, patients with a final diagnosis of MINOCA of unknown cause may be treated according to the secondary prevention guidelines for atherosclerotic disease. Now, a special focus on CMR in MINOCA. CMR is very useful in differentiating ischemic from non-ischemic etiologies. Ischemic etiology is consistent with myocardial infarction, while non-ischemic is consistent with myocarditis, according to the different patterns of late gadolinium enhancement. So CMR characteristics of myocardial infarction, most of the patients have wall motion abnormalities, edema, delayed enhancement. Only 1/3 of patients may develop microvascular obstruction. While in myocarditis, edema and delayed enhancement are the hallmark for its diagnosis, with a minority showing wall motion abnormalities. Takotsubo cardiomyopathy mainly shows wall motion abnormalities, most often in the apical segments, with less commonly edema and delayed enhancement in the CMR analysis. It's noteworthy that almost 30% of patients undergoing CMR in MINOCA showed no abnormalities or inconclusive diagnosis, and also it was found that almost 41% of the patients, the CMR modified the original diagnosis in this single center 10 years CMR data of MINOCA. What about the treatment of MINOCA? According to the Swedish Heart Registry, it was found that patients treated with statin and RAS inhibitors had better MACE on long-term follow-up compared to those not treated. Regarding beta blockers, only secondary endpoints were significantly decreased among those who were treated, while interestingly, dual antiplatelet therapy showed no significant difference between those treated versus those who were not treated. Similarly, the Khmer IH registry, the Korean registry, showed the benefits of RAS blockers and statins in decreasing all-cause mortality among MINOCA patients. Regarding DAPT, the routine use of intensive DAPT regimen in MINOCA might be inappropriate and even harmful, and personalized treatment according to the underlying pathology should be implemented. We are awaiting eagerly the results of the MINOCA BAT study, referring to beta blockers, ACE and ARB's treatment. This is a 2x2 factorial design randomized trial in which patients will be randomized to one of 4 arms, either receiving both beta blockers and RAS inhibition, or neither of them, or alternatively one of those 2 drug groups. Almost 3,500 patients are planned to be recruited with outcomes planned for up to 4 years regarding death, recurrent heart attack, stroke, or heart failure. Now there is a call for an individualized approach for treating MINOCA patients. So unlike patients with obstructive coronary artery disease, MI-CAD, which have standard treatment lines, those with MINOCA, we have to tailor their treatment according to the underlying endotype. What about the prognosis of MINOCA? According to the Virgo trial, which compared the outcomes of 300 MINOCA patients to almost 2,300 patients with MI-CAD, the mortality was not significantly different over 1 year between both groups, regardless of the gender, whether males or females. On the other hand, the larger ANZAC's Quality Improvement Registry from New Zealand, which included a larger patient cohort of MINOCA, almost 900 patients, showed that patients with MINOCA had higher hazards and risks of mortality compared to those with no cardiovascular disease, and patients with obstructive coronary artery disease had still higher hazards compared to MINOCA. This cumulative data from different registries with almost 80,000 MINOCA patients that was published by Pathophysiology in the EC Congress 2019 pointed out to the fact that the overall MACE of MINOCA starts with like 4% percentage of overall MACE at the in-hospital course and gradually rises up to reach 9.4% by 1 year. So this means that the MINOCA has to be taken seriously and has to be managed appropriately. Regarding the comparison of MINOCA to MI-CAD, regarding all-cause mortality, reinfarction, and the overall MACE, the patients with MI-CAD consistently had higher percentage of events compared to MINOCA, while in heart failure and stroke, they were comparable between both groups. Comparing MINOCA to those without having myocardial infarction, all-cause mortality was consistently higher among MINOCA patients compared to those having non-MI at different time intervals. Now back to our case scenario, we advise for this patient, which investigation would you choose? Would you do a CT angiography, a CMR, an IVUS, or an LV angiography? Well, with the patient still in the cath lab, as we have outlined, LV angiography is the proper approach to be performed. Then IVUS should be done to the LAD to outline what the irregularities stand for. So what we possibly see in this IVUS still image in our figure, we can see a plaque, eccentric plaques starting from 6 o'clock up to 12 o'clock. And we can see that there is like a flap which refers to the presence of a plaque rupture. So this outlines the underlying cause of MINOCA. So what's next in the investigation? Well, I would do a CMR. According to the latest guidelines, CMR has been outlined as a very important tool in the working diagnosis of MINOCA. So the MRI shows the late gadolinium enhancement in the basal segment of the anterior septum, which matches the vascular territory of the possible infarct-related artery, which is the LAD. Finally, the key points to conclude: the concept of a working diagnosis is a crucial part in the contemporary management of MINOCA. MINOCA has different underlying pathophysiological causes. It is important that healthcare professionals are familiar with this syndrome so that patients are appropriately identified and treated. The prognosis of MINOCA is overall better than their AMI-CAD counterparts. This is inconsistent among different underlying etiologies. Management of MINOCA is based on limited evidence, and there are no prospective randomized controlled trials so far, and individualized treatment based on the underlying etiology and mechanism is the best approach. Thank you very much for your attention.